next year. Bill has a background in system engineering, operations research, has been at Stevens Tech for some time, where he mixes computation and computation about social processes, so an early computational social science. And you were at Georgia Tech for a while too, I think, right?
Yeah, I was retired from there in 2012.
Yeah, right, okay. And I'm familiar with Bill's work on healthcare systems, but he's going to tell us about other things as well. And so, welcome, Bill.
Okay, well, thank you. Appreciate the chance to be here. It's a little farther than I realized. It was well over an hour Uber ride to get here from the district. So.
Yeah, we say we're in Washington, but we're really, because we're outside the Beltway, we can argue that we're not really part of the whole swamp, I guess.
Well, actually, you know, it's interesting. I find the traffic in the district isn't as bad.
Oh.
It's getting in and out is the problem. Anyways, I'm going to talk first about what computational social science means to me, and then we're going to talk about it at several levels in terms of processes, organizations, ecosystems, and society. Then I have just one slide on the tools we employ, because I'd be interested to hear what tools you employ. We're quite eclectic in terms of the tools we use. So what does this mean to me? Because I'm not really a social scientist. So I tried to put it in terms that might be meaningful to you and to me. And I'm usually interested in understanding and design. I'm trying to design policy, management policy, social policy, et cetera. So I'm actually less concerned with doing science than I am with solving problems. Okay, but I don't think they're completely distinct. And we'll talk about things ranging from individual hospital processes to all of the economy in these examples. So first, scaling and optimization of medical innovations. We've done several studies in this area. And the basic problem is there's randomized clinical trials or other kinds of trials that prove something works for, say, 700 patients. And it dramatically lowers their risk of diabetes or heart disease. And now they want to scale it up for hundreds of thousands of people or more. And what they discover, what we help them deal with, is that little things that weren't such a problem for 700 people are suddenly huge economic losses at 1 million people. Okay, so you have to redesign things. Now, interestingly, in the medical profession, the way they would redesign things, because they're all based on empirical science, is they'd have a lot of meetings. They'd finally decide how to redesign the organization. They would do it, and after 3 years, measure whether it worked. And what we're typically doing with them is considering hundreds of reorganizations in an afternoon, computationally, which I know you don't find surprising at all, but actually a lot of the medical folks do, that you can actually think about doing it computationally. So the basic problem here is how do you stratify the populations and tailor interventions when you want to scale up. There's also a lot of the health problems we're involved with now involve delivering health to people's home. And so then the whole logistics of providing population health becomes an issue. And this is sort of a standard industrial engineering problem, but often they're doing it in a way that's so inefficient. In Indiana, they require people to come to the hospital, say drive 100 miles in, 100 miles, check into the hospital, then go back out to your region, spend the day in your region, then come back into the hospital and check out again. Indiana state law, that they had to do that. Okay. In Philadelphia, the group we worked with, they're routing advanced practice nurses to people's homes, and they never thought of actually putting the person's set of clientele in a geographical area. So people are spending enormous amounts of time driving. These are just straightforward problems that undergraduate can solve. Most of the problems we look at are multi-scale problems. And so here we have the people, the clinical practice clinicians, patients, et cetera. But their activities occur in the context of processes that deliver capabilities and information and capture outcomes. These processes are owned by organizations. Often you go to a hospital and maybe every section is labeled, Acme Hospital, but they'll all be separate businesses really. And so if you're the one who owns the MRI, guess what test you want people to have? MRI, right? And so that's a significant problem. And then we've got our overall health ecosystem, Center for Medicare and Medicaid Studies, Congress, et cetera. Interestingly, in the government, they try to control healthcare costs, but they don't attach any value to people being healthy. Okay, and so when you say, well, you know, if these people are healthy, they'd be working, they'd be paying taxes, et cetera. Well, the people concerned with healthcare costs say, well, we don't get any of that money. Well, but of course, for the whole ecosystem, we're better off if people are healthy. So we look at it at multiple levels, as you'll see in a second.
Though just as a footnote on this, so I think that, you know, we implicitly do, everything we do is implicitly multi-level. We usually don't highlight that, but we should. But do you have a sense of, for example, so is it the case that for many of the problems in which you work, there are in fact, like, you know, 2 or 3 or 4 levels? Or, for example, notionally we would just talk about kind of like, you know, the individual level and then kind of an aggregate level. Or do you think that having these intermediate levels
We usually start conceptually with 4 levels. It could be by the time we actually are programming anything, there's not really 4 levels.
Okay.
But conceptually, it helps to think about it that way. I just gave a talk a couple days ago in California. We've applied this to universities and how you can represent research universities. And your College of Engineering is using my computational model of universities. And now I've got 12 other universities signed up to try it. My basic notion and basic thesis is the higher education cost bubble is going to burst, and trying to see the conditions under which that might happen. And it'll vary for different universities. But for example, the last 2 years, foreign student enrollment in American universities has gone down. Online programs are getting increasingly sophisticated and higher quality. There's some other forces you can just see happening. But anyway, so that's the way we look at health systems. Now for this class of examples we're working at, we end up with this kind of sort of operations research kind of model. We've got the data is red, and the models are yellow, and key issues are green. We mark off models of disease incident progression. We have patient flow for each disease and stage. We have interventions by disease protocol. This creates a network model of patient flows that are consuming various resources. This is parameterized by claims data. We have a demand on each network as well as the overall flow of patients. Our patient and cost data allows us to come up with a economic model so we can see what the network's producing revenue and go on to network performance. Now the key trade-off that all the users want to do is basically decide what intervention protocol they want to use depending on the macroeconomic policy, depending on how they get paid. The biggest issue right now with health providers, we work with 10 major providers, is uncertainty about the payment system. It's not clear, and they even will comment, you know, we can go ahead and optimize our system, our delivery system, based on the way the payment system is now, but we're sure just as soon as we get good at it, they'll change it. They have no confidence in the government maintaining a consistent payment system. And so this is the basic set of models we use. So this is some work we did with Emory for maintaining the health of their employees. And we were concerned with reducing diabetes risk and reducing heart disease risk. And they had taken 700 patients through this. And for the people at high risk of diabetes and heart disease, they were changing their lives. It was dramatic. The problem was they were sampling their population randomly, and 90% of the people were getting a full court press to no benefit because they already had the minimal risk. But they wanted to be egalitarian and do the same thing for everybody, so everybody got a body scan. Everybody got $2,000 of blood work, where they really should have looked at the high-risk patients and treated them with a full court press and done something light for the everybody else. So at the ecosystem level, we could adjust various parameters. We could use either national data sets or their data. We could run it till 65 to 80. In retrospect, I wouldn't have picked termination age as the label there. And then we could also talk about risk reduction. You can't see here, but there's some tick marks here about what they're actually achieving, and they can try to see if what would happen if they do better and worse. And then some of the entry parameters.
So if you're kind of on the termination age, are you incorporating, if it's 80, are you incorporating Medicare or?
Well, no, we're talking about the reduced costs of healthcare. So all of this is premised on reducing downstream costs. So we are saving money from Medicare, but they're not paying anything for it, which is a problem in itself. So here, excuse me?
In theory, an ACO would be a structure that would be able to handle like that,
Sure,
but,
sure. I mean, basically, the bottom line here is that the government should be incentivizing employers to keep their employees healthier, and it would be a less burden on Medicare. But the CMS has no way to do that, to incentivize employers. This is just a snapshot of what's happening with the patient group right now. Who's in service, who's out in life. This is just a small moment in time. The reason I present it is that the clinicians really like this. We did this sort of to make sure everything was working. But the clinician liked it. They said, wow, so-and-so's really doing that right now? They have no way of knowing that, but of course they could. So now what's going on in this organization is this, which is nothing about how they think about it. Okay, the health coach or health partner is central. Everybody's assigned a health partner. They aren't clinicians. The ones I worked with were, one of them her other job was an aerobics instructor. They were tremendously motivational in terms of getting people to comply with what they were doing. And so this is the flow through assessment and goal setting, execution, facilitation, and maintenance. And these are the higher level results. When we scaled up what they were doing at that time for the whole Emory covered lives of 60,000 people, they would, the return on investment would be minus 96% per year. It doesn't get much worse than that, right? And so we computationally reorganized and were able to get a 7% return. And we were doing this in a room like this size with big screens, with members of their team around, members of our team. We were just going what ifs back and forth. If we run it till 80, the return is 30%. Okay, because we're putting people into the Medicare system that don't have diabetes and don't have heart disease, et cetera. So there's huge benefit of that. We did a study a few years ago on, is it worth investing in people? And actually, a book came out of it. And one principle that emerged was that when the investor is not the same organization as the organization that sees the return, the investor sees it as a cost and tries to minimize it. Okay? And this is an example where the biggest benefit is not flowing to Emory, but to CMS. Now, interestingly, you notice here, while the provider organization is okay budget-wise, it jumps around a lot. And the reason is because when you get a high risk, patient high risk of diabetes, you can change their life in 6 months. And if you get 2 or 3 in a year, you save a huge money, because the only way they get paid is risk reduction. They're not paid for their costs at all. They're just in the risk reduction business. So when you get high risk patients, you make more money. When you don't happen to get any high risk patients, you maybe have some losses. Now, this served to convince them, even though this is so obvious, and we said it up front, why don't you target high risk people rather than just randomly picking people from the population? And they finally agreed when they saw the economics of this. So basically the bottom line is we helped them to computationally redesign the system, create a full court press for 10% of the people and a light version for the other 90% of the people.
And so that return is for Emory itself, or is that return kind of for if you?
This is Emory HR make money keeping their people healthy. So Emory was that. At Vanderbilt, we worked on people who had diabetes and heart disease and hypertension. So how do we get the chronic disease management? How do we keep that working? In Indiana, we worked on Alzheimer's and how do you keep people out of the emergency department, out of the admissions to the hospital. And one experiment we ran with the data we had there's no way to cure Alzheimer's or to reverse it. But we ran this experiment with our Markov model of disease transition of what happens if you could slow down the transition from mild to moderate by just 10%. Okay? That would save half the Alzheimer costs in the country. Now the reason is because people don't get Alzheimer's till they're later in age. And if you slow it down a little bit, they never get to the nursing home.
They're going to die of something.
They die at
else.
home, which most people would prefer. Okay, and those are dramatic savings. And we're now working with a foundation who's very interested in that. We'll see whether that pans out. Working with Penn Medicine, chronic care for the elderly after leaving the hospital. They use advanced practice nurses to go to their homes, make sure that everything's going well. 2 of our research members went on rounds with the nurses to people's houses 2 separate times, and they both reported back the same finding. They said, you know, these people's medical problems are small compared to their social and economic problems. That's what they need help with, and the nurses, when they go to their houses, would spend time focused on those, not on their health, because that was all managed. And then we've got a project that's slowly perking along at Sloan Kettering, where we actually put RFID tags on everything that moves, patients, clinicians, equipment, etc. And basically, once you do that, you realize you have a lot of capacity you didn't realize you had, because you now know rooms are empty. You now know where equipment is. And so, for example, with the infusion pumps for chemotherapy, they were going to buy more of them. They discovered actually they had a surplus of them. They just didn't know where they were at any point in time. So these are all similar examples.
But give us a sense that, so when you build these models, you have to obviously do work on the interface stuff so that the practitioners can make sense of it, et cetera.
Right.
But then you also have to work on the model guts, and you have a lot of expertise on how the healthcare system works.
Mm-hmm.
But give us a sense of just like how much work is involved in bulking out those models of the underlying process to get them to work properly. Is that can you do stand off the shelf stuff for that, or do you have to invent that yourself?
What's pretty much happened is that you take about 6 months to really create the right social connections with their team and understand each other, and the whole idea of mapping out their processes, etc. And then the programming the whole model and getting it working is a few days.
Okay.
And then interacting with them, because in general, we've done this so many times now. Interacting with them, the general response we get is, oh, gee, now that I see this, could you do this? Could you do that? Etc. And they help us debug things, like we may have misinterpreted something. So there's a lot of iteration that way. But that's sort of fixing things, but it's also sort of co-training. We're learning more about their organization. They're learning more about how to think this way. And so one really interesting thing we had with this one. So if you take the transition care management program that Penn pioneered, it basically is clearly better for the patients. All the randomized clinical trials show that. All the comparative effectiveness studies show that. But it costs money to implement, and Medicare won't pay for it. So the hospital has to absorb that. They end up having to spend a couple $1,000s a patient. Now the payer gets huge benefit because people are not readmitted to the hospital. There's no more charges. So when we did the analysis, we analyzed all 3,000 Medicare hospitals in the country. And for 83% of the hospitals, it does not make economic sense for them to comply with this policy. It's just, they lose too much money. But then we found, interestingly, we had in the model a payer's view and a provider's view. And we had several providers and payers on our advisory board. When we showed the payers the provider's view, both payers, United and CareFirst, said, gee, we're saving a hell of a lot of money by them doing this, and they're just losing money. We see why they wouldn't want to do it, although we would like them to do it. So they turned to the providers and said, hey, why don't we just split this? Okay, just by seeing the 2 different views. So that was very interesting. It wasn't like we derived the split. They just brought it up once they could see other people's view of the whole problem.
When you have a student who works on these kinds of things with you and helps you, does that student have a significant background on healthcare policy?
Well, they do now. We got a team of about 4 or 5 people. And then when we work with the client, they usually have 3 people. This was a Robert Wood Johnson grant. This was a CMS grant. So,
I asked one because in our department we have people with many different expertise, national security, et cetera, and economics, finance. We don't have much work on healthcare, but that's probably just, I'm not quite sure why that is.
I've been doing a lot of work with MITRE lately, consulting work. About a third of MITRE's business is healthcare. And they have very little healthcare expertise. They have some, but I've been working with teams of mainly engineers, and they're very, very sharp people, but they don't understand the domain at all. And so my job is to help them actually express what they're doing in things in a way that's meaningful to the healthcare world.
Have you met Kevin Comer? Since Kevin would be a good connection there, since Kevin recently
MITRE?
finished up at MITRE.
There's the guy in the modeling and simulation team there who has affiliation here, and he works on, he
Who is
did
that?
some simulation. So Kevin Comer, we'll get you the contact
Comer,
information.
yeah. I've heard the name, I don't think I've met him.
You did affordable healthcare, right?
Yeah.
So now let's look at the organization level. And here we're concerned with health provider corporations' response to the Affordable Care Act. The Affordable Care Act has led and continues to lead to the highest level of mergers and acquisitions of any segment of industry. Basically, people are going for scale. And so this is really not meant to be readable, it's just meant to say all the different players have a lot of different choices they could make. And we interviewed, I gave a talk at a meeting a year and a half ago or so, and it was all healthcare CEOs. I gave a talk on enterprise transformation. And then they each presented their strategic plans for how they were approaching the Affordable Care Act. It was great. And then we went out and interviewed 10 more. And they said, you really only have these 5 choices, and you can pick a mix of them. You can acquire other providers. You can invest in highly profitable DRGs, cardio, cancer, ortho, make a lot of money. A lot of other things are losers. You can invest in population health, and we'll come back to population health in a minute. Improved efficiency. This, unfortunately, is expensive and slow if you actually try to improve efficiency, or you could develop your own health plan. You'd be your own insurer. And so we developed a simulation of New York City, the whole healthcare ecosystem in New York City.
Well, in that ecosystem, Bill, when it comes to the companies involved, does it make sense to distinguish between, for example, the Aetnas of the world and Humanas and things versus a hospital? I mean, are they really?
No, we in this example we kept the payers as externalities.
Okay, I see.
Okay, and we just focused on. So here is in our immersion lab, we have a simulation of all of the 66 hospital corporations in New York City. And we're basically trying to predict who's going to buy who and what's the consequences of that. And by the way, this is 8 by 20, 180 degrees, and the other walls are all screens. MITRE in Building 4 has an amazing immersion lab. It's got 45 tile screens. So I presented like some of this stuff there, and it's about 20 feet tall and maybe 60 feet wide, and it's just, you're just immersed in this world. It's a great, great presentation environment. So here we are, and this is seven or 8 different models that are linked and affecting each other. We looked at the hospitals. This was 44. It was actually 66 in the end. And here's what we needed to know about each hospital. We basically needed to have their financial statements for the last 15 years. No one would give us those. However, if you go into publicly required filings, you can reverse engineer their financial statements. And so that's what the student, who's now a faculty member, did. She went in, and it took her about 6 months to reverse engineer all the public filings and have what we needed to basically run the models. We looked at various strategic scenarios: maximize revenue, acquire providers with compatible DRGs and large patient populations, become the tertiary care partner for your acquisitions. Rather than acquire, you can merge if you're similar size. You can maximize profit, and I'll come back to that one in a second. And you can do turnarounds. One thing we learned here is that if you think you're gonna turn around a poorly performing hospital, it ought to be doing something you know how to do. Right, it's not just to have bad financials, it's gotta be something you already know how to do well. So, the overall results of running these simulations is that in 10 years, there'll be 20 hospitals left. Not buildings, corporations. Buildings will still be there. With a few exceptions, the remaining 20 are path dependent. It's not the same 20 all the time. For example, the Hospital for Special Surgery is the most profitable hospital in New York City. They just do orthosurgery. Whoever gets them first changes the game for everybody else from then on. And so what happens in typical in the simulation, there's all sorts of parameters, but the best financial hospitals, the ones that are in best shape, will all bid for this hospital. Well, one of them will get it. And then the others need to turn their attention to something else. Well, now the one that gets it has a head start. So we worked with Columbia Presbyterian, Northwell, Sloan Kettering, and Mount Sinai as people. We had, I think there were like 30 or 40 different health teams came in and evaluated the models. A lot of consultants. One example, when we presented the results to Columbia Presbyterian, they've been #1 in New York City for many years. There are scenarios where they end up not even in the top 5 after 20 years. And they were shocked. And we showed them how the strategies other big players adopted caused that to happen. And the interesting recognition that they had was that they never thought that they should base their strategy on what everybody else is doing. Right? We're #1. So we decide what to do and everybody else has to accommodate us. Well, it's not true. As you know, General Motors discovered many years ago. And so the hubris of the top players is often interesting. We have had several discussions recently, past few months, about developing the same thing for Washington, D.C. and being able to run experiments in Washington, D.C. There's been a lot of enthusiasm. A lot of these large-scale problems I work on, I get a lot of enthusiasm for all the key players, but nobody feels like they own the problem. So they don't want to act. So it takes some time sometimes.
For Columbia Presbyterian, Bill, does being #1 mean they serve the most patients?
Most revenue, yeah.
Most revenue for the whole system.
Yeah. It's interesting because New York City has several of the top hospitals in the world, and so it's much more competitive than any other place in the country. Well, Annie, who did this, she had some Medicaid data, and she was identified Medicaid data, so she knew the patients because of the work with Morehouse in Atlanta. So she created social network models of the different cities around the country. The interesting thing was, if I remember correctly, Boston is hospital-oriented. The big nodes are the hospitals. Seattle's clinic-oriented. Houston is physician organization-centered. And it struck us from looking at this that healthcare isn't the same in all these different cities in terms of the dynamics of how the network works. Yet, CMS wants to have the same policies everywhere. And incentives would mean different things in these different cities if you could design that.
If you did Washington, would you include, the tricky question is, would you include Hopkins in that or not? Right?
Here would be Hopkins and MedStar, right? Would be the big 2 players.
Hopkins is so big, where you have to.
Yeah.
Even though I think it's just far enough away where a lot of people in Washington may not want to go there, but
yeah.
But they play with.
Okay, now we're going to go to the ecosystem level and talk about population health. This is a mainstream effort we've been involved with for about a year now, and we're looking at integrated delivery of health, education, and social services. Okay, so, our test case is opioid abuse, and we're trying to look at how do you give the people who need it an integrated suite of services, where instead of them having to, have a doctor and have a psychiatrist and have a social worker and look at housing, which, these people are not in a position to really manage this. It's surprising anybody's in a position to manage it. So let's just talk about what that enterprise is. And we've got where we're at in them now. There's no results to report. This looks like the same diagram, it isn't quite. We use the same shell over and over again as a starting point. And so some of the words are significantly different here. So basically, you can think about it in two levels. Society, organizations, policy makers want to decide how to allocate resources across alternative interventions to improve health outcomes. People and processes, and people aren't always patients, it can be just participants who are not yet needing care, have to decide how to engage. And the effectiveness of decisions up here depend on your understanding down here. Okay, and some data points on some papers we've written recently reviewing this whole topic. First of all, substance abuse in the United States, which includes smoking, tobacco, prescription drugs, and illicit drugs, the cost of that is $750 billion a year. This is a big deal. For people who have diagnoses of substance abuse, the average time from when they get the diagnosis until they enter treatment is over 10 years. Partially because they don't want the treatment. Okay. The average time from when they want treatment till they initially begin treatment is over a year. And so the people just, if you think about it as a queuing process like we are a little bit, people just balk or renege. The times are just so long. The research questions we're looking at, can upstream interventions, educational social services, decrease incidence? An interesting conversation with one of my bartenders lately. There's quite a few pubs where I live in Cathedral Heights, so I'll go to lunch there. And this young lady I know pretty well from over the last year or so. And we were talking about opioid abuse. And she made an interesting comment to me. Maybe you've heard this yourself. She said, people my age, I think she's like late 20s. She says, people my age, something that really surprises me about them is, and I don't do this, but I see it happen over and over again. We'll be in a party and someone will have a handful of pills and say, try this. And you have no idea what it is, and people just take it. She said, this is very common. So I talked to some of my colleagues when I was up in New York teaching this week, same age group, and they said, oh yeah, that's pretty common. People have no idea what it is, and they just take it.
My friends are no fun.
What?
I said, my friends are no fun.
Well, they were alive, though.
Is this really something new, though? I mean, going back, say, to the 60s or something, when people just said, here, try this, and they did, because it's based on the social network, not necessarily information about what they were being given. Is this a new phenomenon?
Yeah, well, I remember the 60s, actually more than I remember the 90s and 2000s. And I don't remember that quite I don't remember that quite so blatant.
Yeah.
And the other thing, of course, then is there weren't as many choices. You couldn't get elephant tranquilizers, for example. Where was it in Georgia, they had this thing, they were passing out elephant tranquilizers, and everybody was just dying instantly.
Turns out they weren't elephants, yeah.
Yeah, right, yeah. How sensitive are the results to population engagement? I think engagement's a big issue. What about the second order effects? How do we take into account they lead longer, more productive lives? The loss of productivity and the loss of being in work is huge. The tax losses, I think I estimated it's about $150 billion a year. What about the fragmentation? This is a big issue we're looking at now. And if you can get rid of the fragmentation, how well can you perform? So the basic model we've been looking at is that the problem is people balk, they don't enter treatment at all, or they get in it and they renege, which means they just leave. And we've been looking at the probability this happens. We've got some pretty good data on how time delays affect this, but now we're looking at the behavioral economics interactions and social networks to understand the impact on patient engagement. And the whole notion, the design of integrated services will support people to engage. I think this is a real problem where we actually know what to do for these people, but they don't engage in getting it. And in part because there's just all these different pieces, and you have to understand a lot more than they want to do that. And we're headed back here.
Is law enforcement engagement part of one of the research questions? I mean, law enforcement coming in with the opposite side, we're out here to help, we're here to arrest you. And through that, you may get help, but that's not the primary goal.
Well, that's come up repeatedly. We're working on a big project with MITRE in this area right now, and they've continually brought up law enforcement. Of course, this $0.75 trillion also includes a bunch of money for incarceration and law enforcement.
Okay.
So we haven't looked at that as directly as we should. Right now, we're trying to look at the patient and the provider and the payer as a focus, and then we're going to expand to the suppliers and regulators, the pharma companies, the device companies, and we're using for the patient and the provider and the payer, we're using utility theory and prospect theory and game theory to represent those interactions.
You represent all the individuals, or would you represent just some kind of typical individual in those models? Like all
Well,
patients?
probably so far it's probably been typical. Most of the other ones I showed you, we actually represent each patient, but this population is much bigger. The problem when you represent a typical patient, you basically tend to reduce the variance in the system.
Right.
Right, and so it may seem a lot less crazy than it actually is. Now I'm going to switch away from health, and we've had another effort with IBM and Accenture and General Motors looking at driverless cars. This is one of my favorite cartoons about this. I've done a couple of blogs recently on this. If driverless cars are fully successful, there'll be 1.5 million fewer deer killed per year. And about a quarter of the Florida cougar population is taken out by cars every year, so there'll be more cougars. But I don't think the cougars can keep up with the deer. I don't think it's just not enough of them. As another bartender in one of the restaurants in my building said to me, I've been a vegetarian for a long time, and she knows it, but she's really into meat. And she talks about all kinds of meat she eats. And she said, for a while I had rabbits, but the problem with rabbits is they can reproduce much faster than I can eat them. And I think the deer and cougar is a bit of a problem. But anyways, so we're looking at driverless cars and their impact. You probably know about this SAE framework that from no automation to complete automation. But we're less actually concerned with the car than we are concerned with the existence of the car. Let's assume all the technologies worked out. What happens in the economy? So this is a system dynamics model. I obviously can't go through in great detail that we developed for how cars get adopted, what happens with the insurance industry, what happens with the auto finance industry. And this, in developing this model, I think, as I recall, the PhD student that finished last spring, involved 80 meetings with subject matter experts at Accenture and the car companies to develop the model. And it was just constant going back and forth. But let's look at some of the results. So the traditional vehicle sales, cars on the road, excuse me, are going to plummet. The personally owned but semi-automated cars will go up. Okay. But then over in the green, we start seeing complete autonomous vehicles. So we're predicting they'll start to come in at about 2025. That's actually conservative compared to some of the companies. And so we see what's happening with the replacement of cars. Now the effects of this are really pervasive. What's likely to happen is many people won't bother to own a car, or they won't own a second car, because these vehicles will be expensive at first. There's a lot of technology on these cars. And so they'll end up going to driver services, and people say, well, people will never do that, but it'll just be like Uber without a driver. And it depends on how confident you are, and that'll change over time. I wasn't worried there wasn't an operator in the elevator when I came here. And so this is some of the results. Some interesting things here. I'm going to show you the impact on insurance companies shortly. But we've worked a lot with GM on this. And the question they have is who's going to buy the car, which is a pretty reasonable question. Because if it's going to be bought in fleets by Uber and Google, et cetera, it's going to be a completely different economic situation than individuals buying cars. But they did this nationwide survey, and the results just amazed me, because the results said the typical buyer of a driverless car, it will be the 4th car in their family. And we looked at the kind of stuff, research we've done, we said, we think that's crazy, that people are going to buy this as their 4th car. I mean, first of all, how many families have 4 cars? You know, I mean, there are some, certainly, but the other thing is we disagreed with their pricing model. So we did the system dynamics model. They did all their work based on surveys. When they saw the system dynamics model, we spent several hours there, went in great depth. They said, actually, we like your assumptions better than ours. The way they got to us was interesting. And teaming with Accenture on this, you'll see the next slide. When we got those results, they issued a press release, really slick press release on these results. It was picked up and highlighted by Fortune magazine, and the GM executives heard about it. And I already have some colleagues there anyways, and they wanted us to come out and explain. And the comment they made that was most astounding was, we are projecting a fundamental change in the insurance industry and the auto finance industry. And they had, without realizing it, assumed that that part of their world would just stay the same. And they had to just worry about them and their car, GM's car, right? But now they're saying, gee, the whole ecosystem is going to morph, not just us and our cars. And how do we deal with that?
Before you go on, Bill, this is quite a dramatic chart here, the increase in vehicles. So you told a story about millennials, other people possibly not needing as many cars. So just what is the intuition for why the rapid growth?
Well, there's a couple things. One is, you probably know the millennials, the number of young people who get their licenses dropped from like 95% down to 70%. People just not bothering to get licenses. Okay, so that's sort of a harbinger of this. And the whole sharing economy is becoming increasingly common.
But hang on, but that's what's confusing me. So, but this is a monotone increasing number of vehicles.
Right. Because what's happened is we assume with some data that much younger people, under 16, and the elderly will be using the vehicles. Okay, so the mobility of the elderly will change dramatically. And so I don't know if you've read Atul Gawande's book on mortality, being mortal, but he basically is a great book. He says there's 3 things about successful old age: retain a sense of purpose, maintain your social connections, and stay mobile. And so this will be a boon for them.
And just one quick question, like the personal semi-autonomous vehicle, like they're obviously by that chart already in the market, so.
Right, and in fact, one scenario is that the way we eventually get autonomous cars is our non-autonomous cars become incrementally smarter.
Yeah.
And they're already there. There's been a lot of projections that the way the car is going to happen when it's fully deployed is that you'll just have more and more features in your car, and eventually you get to the point that you can be driverless, and you'll start to experiment and accept it.
So even in 2000, you've got close to 50 million semi-autonomous vehicles on the road.
Right. So there are cars with, the
Is it like adaptive cruise control?
intelligent cruise control,
Okay.
side sensors, etc. In fact, there was a Consumer Reports that came out and said, you're going to start to buy your first version of your autonomous car this coming year. And they had all the features on the different cars, and they said these will be key to the autonomous cars, and you're going to get them in that next car. Yeah, so that's what that means. So, now why do we focus on the auto insurance industry? We do a lot of work with them because of Accenture. We have a lot of their executives teams come to the immersion lab. We've found that executive teams like to be in the lab. Some of them have an interesting rule. They will not allow any PowerPoint to be shown. Because anything show us has to be live and be real. But anyways, it was one dinner I gave a talk at about innovation stuff, and there were 4 tables of executives, and I said, I actually used the example of the shipping container, which totally disrupted the Manhattan manufacturing industry. All the shipping moved to New Jersey because there's no place to put the containers. And manufacturing employment in New York City went from 1.2 million to under 100,000. So I asked them, what's your shipping container? And I want each group to talk among themselves in a few minutes, see what your consensus is. 100% consensus, the biggest threat in our industry is driverless cars. Now the reason that is that most states have laws that you can only charge premiums equal to your claims. It's supposed to be a net zero on premiums versus claims. And where you make your money is by the use of that premium money during the year. You invest it in other things. Okay, so if there's less and less accidents, the premiums have to go down by law. And so here we see what happens with the insurance industry. Until we really get significant penetration of driverless cars, we're not going to get the no accident world. So we still like this, but then it just plummets from the lack of accidents. And there are some ideas for new kinds of insurance, where you have cybersecurity insurance on your car, infrastructure insurance. Now, it may not be the consumers are paying this, that somebody else is paying it, but there'll be some other kinds of insurance. And we did the same thing for banks. That paper hasn't been published yet. I didn't realize till we get into it, the average car has 4 loans on it, once when it's new and 3 when it's used. And the banks are, I thought they were really sophisticated about this. They were really concerned that there just won't be any used cars, because these cars will be used 24/7. Basically, you know, they might put on a couple 100,000 miles a year, and every 2 years they'll just be totally replaced. And so that really affects the auto finance. Auto finance for banking and auto insurance for insurance are among the most profitable lines of business. And it's interesting to think about it. It's because they're dealing with an individual consumer, and how much power do you have, right? When they have to start selling their fleets to Uber, and they're selling like 10,000 cars at a clip, Uber's probably going to want a deal. Right? So it's going to change it. You know, Ford has come out and said they're a mobility company now, not an auto company. GM has announced they're no longer going to invest in internal combustion and diesel engines. I mean, they'll still be there for a while. But the companies are really trying to morph themselves. So across the spectrum of all the things we're doing, I thought it would be interesting to talk about how do we do it. First of all, a lot of our models just start off in Excel. I usually try to get the team to not like start programming the first day, and just think through about how you're representing the problems. And usually we try to just look at, if we do it with expected values, no variability, we often can just compute the answer. We do it all analytically. And that gets us to the point that we understand what we're doing. And also it provides a baseline, because once you do put together a simulation with a lot of variability, you ought to get the same mean within some confidence level, right? We use R quite a bit. Any logic allows you to do agent-based discrete event and system dynamics in the same tool. We use that a lot, although we tend to use VenSim for system dynamics. It's just more powerful than the other ones here. And then interactive visualization, D3 is what's used most, but Tableau some of the time. I thought it'd be interesting at this point, just what tools do you guys use? We also do a lot of Python stuff, you know, right from code, but for example, some of the stuff like the Emory one, we used AnyLogic to get it working, and once we knew what we wanted, it was too slow for some of the big simulations, so we just recoded it in Python. And the test of the Python code for certain parameters, do we get the same answer as AnyLogic? Anyways, I'd be interested in whether this fits into your tool set or you use different
Probably the
things.
best one to talk about is Andrew. Andrew teaches the introductory course where he goes through kind of the whole laundry list of things.
Yeah, mainly we use NetLogo, and then Python. The more of the students here, when you mention Python, everyone's nodding their heads. So Python, Java, we talk about BenSim, but we don't really do system dynamics per se here. But when Ken taught it, he would have used, I think he would have used BenSim, right?
Yeah.
No, well, the
Kept it
preference was
open.
to use any logic
Well,
for system dynamics.
okay.
Well, it seemed to be a far more stable platform. Like,
Well,
any
AnyLogic
sim-
is really fast for prototyping.
Yeah.
One thing we stayed clear of AnyLogic for a long time was because you had to pay for it. But now you have educational usage.
Right.
You can use it free now. So,
Yeah. Any tool that that's not here, that you just use something I just don't know about?
We'll typically code our own models, Bill. And
Yeah.
The main agent-based modeling engine that's widely used here is from our computer science department over here, and it's
Okay.
called Mason.
Okay.
So Mason is a Java-based set of basically a software framework, in which you can also do rapid prototyping if you wish,
Yeah.
once you learn the model primitives. So I would say there's no advantage of any logic over Mason or Mason over any logic necessarily. They both have the same kind of functionality and features.
Yeah.
Mason is a open source software
Yeah.
development project, so a
Okay.
little more in that spirit of things.
yeah, and Mason, NetLogo, and Repass borrow from each other as well.
Mhm.
With respect to many functions, actually.
Yeah. Yeah, we used to use NetLogo and Repast, but it was one of them that's pretty simple. I forget which one is it.
NetLogo.
NetLogo, yeah. And some of the things we're doing with huge numbers of agents, that seems to be.
It's hard to go
a
more than
check.
about 10,000 agents with
Yeah.
NetLogo.
Yeah.
So when you were visualizing your models, like in your decision theater, are you using Tableau and D3 to link to AnyLogic, or are you just using the AnyLogic GUI?
The biggest link is R to D3.
Okay.
AnyLogic isn't as penetrable, because of the commercial status. The other thing I do a graduate course on modeling and visualization of complex systems and enterprises. And interestingly, and there's a project required for half the course. You have to create a immersive simulation environment. And the first semester I did it, the book just came out in 2015. The first semester I did it, all PhD students, they really struggled because they just waited too long to get started, and before they became good at the tools, time ran out. So about 40% of the class could not demo anything at the end. They couldn't get it to work. So the next semester I did it a year later. I ended up getting the graduate students who were really good at all these, and we did workshops outside of class time on each of the tools, and so it dramatically improved the quality of the results. When people didn't have to learn the tool at the same time they're trying to work on whatever intellectual problem they're working on. And so good. So that's
Do you
my
do much-
story.
Do you do much in the way of kind of network analysis?
Yeah, we do, especially social networks. Yeah.
Do you use?
I think when Annie's been the lead on most of that, I think she just programs it from scratch for analysis.
Yeah, here networks are getting more and more involved. So I would say Python and Gephi are the two things really used. Right?
Well,
R.
Huh?
R has good libraries.
When
So
you say-
how is the kind of things I do different than what you do?
We do very little discrete event simulation, and very little system dynamics.
Okay. What about the nature of the problems?
So we haven't done much work on health per se, but I think we're broadly interested in all the social sciences, Bill. And I think the basic point of departure for what we do is we typically will focus on individual actors in some social process,
Mhm.
and then we will try not to shirk on modeling the behavior. So we
Mhm.
typically will not want to say it's just a Markov process, or it's just
Right.
we'll say here's prospect theory, here's some.
Mhm.
You may not know that George Mason has a large experimental economics laboratory where
Mhm.
Vernon Smith won the Nobel Prize about a
Mhm.
decade ago for that work. So there's always a chance to say we don't know how people are going to behave in this environment, so you could go run an experiment and say here's how they respond to incentives.
Yeah.
or something. So I guess that the short version is that we will typically look down on things that don't have a deep representation of individuals in some way, shape, or form.
Yeah. I think it depends, like the stuff we're doing in population health, we are having a deeper representation of patient engagement. But the thing we do in diabetes, I feel pretty comfortable with the Markov model in diabetes, because I don't think it's like a decision to have diabetes, right?
right.
It's a physical process that evolves.
So let me, so when we do, we have we have a bit of work on things like epidemic modeling. So here, I think here's the behavioral version of it, is that when someone gets sick, you want to have them change their behavior. So for example, in your models, when people become, when they receive a diabetic diagnosis, for example, how does it modify their behavior, right?
Mhm.
That's the kind of thing where we'd like to maybe have a suite of possible responses. And some people
Yeah.
deny it, some people react progressively to it, and maybe so there's some.
That's right. Yeah,
Some rich way to-
with the stuff with Emory, we had people, well, they didn't have diabetes yet, but they were very high risk. But we had all this clinical data, what the interventions were and what they chose to do, and we just went along with what they did. But you obviously could, and we assumed that every new cohort was like them, which isn't necessarily true. One of the problems we had was a lot of our data was based on the Framingham data set, the cardio study over 60 years or so. And we did get some pushback that the population in Framingham was predominantly white males, and the population in Emory isn't. But the problem is we didn't have a data set, large data set, for the population there. So we said, you know, this is the best we can do. And we said, if you have other data sets, you know, we would be glad to look into them. When we use the national data for diabetes and heart disease that comes from ADA and AHA, we got certain results. Then we actually got all the Emory claims data. We went through and did the whole thing over again for the particular people in the set, and we got the same results. So in that case, it didn't make that much difference.
One other thing that we do here is that Andrew does a lot of work, for example, on putting maybe, there's some problems which need a geography layer.
Yeah.
And many of the problems that you work on don't seem to require geography so much, right? That's kind of secondary or tertiary.
Yeah, although interesting, the stuff we're doing with MITRE and opioids in the VA, there is a sense that the geography and the rural nature of a lot of the patients is a big problem.
And the networks, though, I mean, the networks coming through the opioid, I mean, social networks,
Mhm.
they're a really large factor in that as well.
Right. Yes, for either good or bad. Yeah.
Just, you obviously work with industry, so how do they take to the agent-based modelling approach? Because I suppose most people have difficulty explaining or getting buy-in or outsiders to understand what's going on. Like, you know, everyone's interested when you go, we model the agent level up, but how do you find?
No, this is an interesting issue, and what we've done with the providers we work with is we get their data and we're able to say this is not a population in general. This is your population. These are all parameterized from your patient set, because they're really concerned about that. They'll, even with the randomized clinical trials, they'll say, well, yeah, that's all well and good for that population, but how do I know I'll get that result with my population? And so we use models that we parameterize with their population characteristics and synthesize the results from the clinical trials by taking a subset of the clinical trials data that has the same characteristic as their population. But if you can tell them it's their population, it has their population characteristics, they usually feel pretty good about it. But when it's just this abstract population, then that's another question.
So with I was really more interested with the automobiles. So was that
That was system dynamics. We haven't done agent based with the automobiles yet. It's just fascinating how people and the social system are going to react to this technology. I did a blog last week on what would happen if the machines just did everything. What would that mean? And I actually think people would be pretty creative in finding new sense of purpose. I don't think it'll be such that. I mean, for example, very few of us actually are in agriculture and we get to eat. Only a few of us pine for having to be back working on the farm, right?
yeah.
Okay, so, and the other question, I'm doing a workshop in late spring. I don't know the date yet here in Washington on the behavioral and social implications of autonomy, because DoD is very concerned about what are going to be the consequences of deploying all this stuff even if it actually does its task well, how does a team work then when some of the team members are not human? I mean, maybe some of you have been out to the Institute of Creative Technologies out on the West Coast, and I was there one
USC.
day. This is DoD funded at USC, and they had this thing. You look like you're working at a movie, and it's in Afghanistan, and they're trying to give food out to the villages, and the colonel would turn around and talk to you, and you could ask him questions, okay, which was pretty cool. And I tend to be a little disruptive anyways, and I said to him, well, how was your weekend? And it just totally destroyed the whole interaction. He was just not prepared for that kind of question. It just was gibberish. But you can imagine if you're working a team where some of the team members are autonomous, you might ask questions, maybe not that one, and begin to question this team member. Oh, he's just a robot. Well, once you say he or she's just a robot, then what does that mean in terms of how you behave? It's a fascinating problem.
So when it comes to autonomy, Bill, some of us in the room have been involved with also in the multi-agent systems computer science paradigm. So that's been around since the mid-90s or so. So early on in that thing, like for example, the same guy who made Mason over in our computer science department has been involved with this also. Somewhere around like 97, 98, the idea came up, or somewhere in the mid-90s, to have basically robots play soccer. And at first was just a hardware version with actual physical robots. And eventually there was a software version, and the idea was let's hold a tournament at every annual conference. Okay. Now, in the year, I'm going to just report to you. So in the year, like I'm going to say, pull out a guess what it was, like 1997, say, at the first meeting of this International Conference Multiscale Systems. Okay, we sat down. We said, we should have a goal for this thing. We're gonna have not only a soccer tournament, but the real goal should be to push AI forward, push robotics forward, etc. Push autonomy forward. Because you have to build a whole soccer team, and people are gonna make autonomous decisions. But they're gonna coordinate team-wise, right? And at that time, we said the real goal here should be we computer scientists should be able to make a robotic team that can win the World Cup. that should be the goal. Okay, this is '97. That tournament has been held every year at the meeting. Okay. So if this is where we were in '97, and this is what it will take to be a World Cup champion robotic team, to beat all the human comers, right? Along that path, I mean, how far do you think that? I mean, how far is?
Well, does the robots have to act human-like?
They have to win.
They can play any way they want.
They can play any way they want. They have to win. Although there is the idea of having a humanoid type player, right?
I mean, the robots could be indestructible. I mean, you just could not stop them.
Yeah.
Right?
But they have to possess the ball. They have to be able to control the ball, right?
So in this blog I did last week, what if the machines did everything? Then of course, what do people do? And there's different paths I go down. But one of them is maybe the robots would keep us as pets. and then we'd have to learn how to chase balls and stuff like that. And then it struck me, most of our sports do involve chasing balls. Right? If you watch basketball, football, baseball,
One
soccer,
ball and many
it's just
players.
people running after balls. How is that different than dogs?
Anyway, but back to my point, I just want to say that so it turns out that what to me is remarkable is that 20 years of progress in this area, and you have, I would say, you have almost no progress. You have very little progress. So if in '97 you're going to say it's going to be the thought way, well, in '97 the claim was that by 2050 it should be possible to have a team, or a mechanical team. The mechanical team can outperform the human team in the same way that Deep Blue outperformed Kasparov in the same way, etc. And we've made almost no progress on that. So I was at a conference in Silicon Valley recently where this was the claim. See if you buy this. The claim was that when it comes to doing things physically, mechanically, even chemically or something, AI is not progressing very fast at all. But on the hardware side, but on the software side is where all the progress is.
Yeah, my son is really into high performance cars, and he bemoans all of the AI with cars and everything like that. And he said, it's going to get to the point that they're going to eliminate all the mechanical side. And I said, well, then the car's not going anywhere. Right? It's the mechanical part of the car that goes places. It's the control systems, the software, not the mechanical part of the car. So the mechanical part will be around. You could try this. Maybe one step with the soccer would be humans wearing exoskeletons.
It's been discussed.
So that would be an intermediate kind of thing. But then the question is, how would you do that in a way they can be really agile.
Can't make you speed up or anything. And then be better for American football, maybe better when you wouldn't get
Right,
injured.
yeah. But there's a Boston Scientific ad, I think last week or week before, with this human wearing exoskeleton and standing on a pedestal and doing backflips on this pedestal. That's pretty agile.
Well, they did have an actual full robot that was doing box jumps
Mm-hmm.
and then got to an end and did a whole somersault and landed on its feet. So,
Mm-hmm.
And that's the company that has the dog too, right?
Right.
yeah.
The dog that runs around.
Yeah.
We did the box jump with a face plant.
So I'll ask you to make a guess. So today in 2008, almost 18 now, if we had to ask you, at what year do you think half of vehicular traffic will be no driver in the car? What year do you think that will be? On American highways, say in Washington
I'd
D.C.
say 50 years.
Well, 50 years from now, so to have half.
Mhm.
So 2067. Well, all of us we're not going to be here by then.
Did you see the thing in The Economist? The Economist had projections of when humans would become obsolete. This was like 2 weeks ago. And they had various surveys, and one group, who were all AI researchers, I think they predicted 100 years humans would be obsolete, and the last humans to go would be AI researchers.
But I'm not surprised as you say 50 years to have half. Oh, I'm inclined to agree with you because it turns out that as a footnote, I'll mention that for many years I worked downtown at Brookings, and across the street from Brookings is the National Rural Electric Cooperative, some old New Deal agency or something.
Mhm.
And when I was there, when I was working down there, they at one point had this kind of just informational setup in the lobby. And what was extraordinary to me was they said that, so even though Edison first electrified, whatever it was, Edison, New Jersey or something in 1894.
1878.
Oh, 1878, okay. They said half of America didn't get electricity until, anybody know this? I was very surprised.
97,
Yeah, exactly. It was basically they had to get the TVA fired up and get rural electricity out there. It took half a century.
We've
more.
looked at a lot of these kind of things, and it depends on whether adoption requires infrastructure.
Yes, right. Sure.
Right. If you can just have it, use it yourself, that happens faster.
Mobile phones much faster for them.
Yeah, we're doing an interesting project with IEEE that's supported by Accenture and some other partners, and we're trying to see whether we can predict technologies emerging and being successful. And IEEE has given us their 6 million articles from 1912 on. And so the question is, and they actually gave us some of their historians to work with us. The light emitting diode, I think, was patented in 1916, but they never had a sense that there would be LED lighting. It was for other purposes, right? And so the question is, what path do these things take? And we're doing light emitting diodes, photovoltaics, and gyroscopes right now. And we're trying to use text analytics. And what they want to get is they want to be able to read the literature, conference papers, journal articles, patents, business articles, say up till 1970 and then predict 1980. And then go through 1980 and predict 1990. And the whole question for us is this even possible to do this? But I've now encountered a lot of people asking that question of can we predict. James Burke in his pinball effect, where he talks about connections between technologies, has two really famous principles he discovers. One is that the primary impact of a technology is hardly ever what the originator envisioned. And the second is that the primary beneficiary of a technology is hardly ever the original investor.
Well, it's better to imitate than innovate, like in terms of the profitability. I think there's a New Zealand economist that wrote the book in the 80s on that. So.
Yeah.
But just going back to like the autonomous vehicles, like,
Mhm.
because I'm quite interested, because some of the reading I've done on it said it's got to be all or nothing in terms of the mix. You can't have 50-50 because the autonomous vehicle won't know how to handle.
Well,
Like the
first they'll have separate lanes.
But then it goes to your infrastructure argument. How are you going to have a separate lane?
Right. Well, in fact,
especially around here, it's all horse and cart tracks, which
well,
are
and
better.
the thing that will sort of flies in the face of separate lanes being the solution is, I forget the company that's doing the autonomous trucks, but they're actually out now. And basically what happens is, it's for the open road, and the trucks turn into a convoy.
Yeah.
And they control off each other, and they're 66 feet apart. And only the front driver is actually in charge. Everybody else is just linked in. They said the biggest problem they have is, even though they're 66 feet apart and they're, you know, going 60, 70 miles an hour, people cut through the trucks.
Yes.
You know, there's about a second apart, you know, people cut through the trucks trying to get across the lane, and it just disengages everything once the car is fired.
Yeah.
And so that kind of behavior is gonna continue, I would think, for a long time. Although you might argue Darwin will take care of that, right? I mean,
Well, that's what I found, like, when I was driving to Houston on holiday, like, it was a thunderstorm, you know, like, so you leave the gap, and that just invited people to, like,
yeah.
you know. But, you know, I was just interested, because, you know, there's still that question about, like, does the autonomous car have the head-on or hit the pedestrian? Like,
Yeah, the ethics issue,
the
yeah.
ethics
Well, the
issue.
autonomous car should protect its passengers, that should be its primary duty, that solves the ethics problem.
So you've decided?
Yes, protects the passengers, that's its job.
Yeah.
They're getting carjacked.
Yeah. I actually think the technology will be ready long before it will be fully embraced. That's where we get the 50 years. Is
So
that,
Dale, in the trolley problem, you vote for the trolley.
Yes, I vote for the passengers in the trolley, whatever impacts them the least, because that's the job of the trolley.
But you know, there are some things, I think the adoption of Uber has been amazing, how people do this with Uber. And I know a lot of elderly people, they use it all the time.
But it's just because
And for
they
them,
use
that's
it
a
because
driverless car.
Huh?
just because it's cheaper, right? I mean, 'cause they can always call a taxi. They just do it because it's cheaper.
Well, it's cheap, I don't think, it is cheaper, but I don't think the price to me is as important as the convenience.
I think it's a human behavior thing.
It's the responsiveness, I think, of Uber and Lyft compared to the taxis that is a selling point for a lot of people.
And especially in New York City, the taxi drivers always act like they're doing you a favor, giving you a ride. Where the Uber driver is much more attentive. And there've been studies that people feel safer in Uber than in taxis, because Uber knows you're there, they know the driver, they know where you're going.
And then they're selling all that data to someone.
Well, thank you very much for a very
Thank
since you're in the neighborhood these days, feel free to not be a stranger. And I think we have many students here who would benefit from your interest. So